Hello everyone, this is the screencast for Group 2. Our study is a comparison of indirect versus direct therapy for the treatment of dysphagia in 2 elderly stroke patients. Dysphagia is a condition in which an individual's ability to swallow is compromised, sometimes resulting in pain or the inability to safely swallow food and liquid. It often results from damage to the nervous system or because of structural issues concerning the tongue, pharynx, or esophagus. Swallowing disorders are a common problem for patients recovering from acute stroke as well, affecting 42 to 60% of individuals in this category. Currently, direct and indirect therapy methods are used to treat dysphagia. Direct therapy involves compensatory techniques to address sensory motor deficits while introducing food or liquid into the patient's mouth. Indirect intervention uses swallow-related exercises in the absence of food or liquid to strengthen the associated muscles. Risks associated with dysphagia are malnutrition, dehydration, weight loss, and decreased quality of life. Also, there is an increased risk of aspiration in which food or liquid enters the lower respiratory tract. Because of the high prevalence of dysphagia and its potential life-threatening effects, it is essential that the most effective form of intervention be identified so that we are better able to serve this population. This study compares the effectiveness of indirect treatment by way of the Masako maneuver and effortful swallow exercises versus direct therapy concerning postural adjustments and PO trials in 2 elderly individuals with oral pharyngeal dysphagia resulting from acute stroke. A conclusion will be achieved by assessing their oral intake ability and severity of swallowing difficulty following each treatment. Based on previous research, it can be hypothesized that direct intervention will prove to be the most effective form of treatment for patients with dysphagia secondary to stroke. In order to qualify for participation in the study, subjects had to have experienced swallowing difficulty for at least 1 month following the stroke, with no more than a 3-month gap between the stroke and the onset of treatment. Those who exhibited other voice or swallowing-related complications were excluded from the study. 2 individuals over age 80 with dysphagia resulting from a cerebrovascular accident were selected for participation. The 2 participants in this study received direct and indirect therapy 5 days a week for 6 weeks. In participant 1, baseline data was obtained, treatment 1, which was indirect therapy, was administered, then baseline was reestablished, followed by an introduction of treatment 2, which was direct therapy, and ended with a return to baseline. The same was done for patient 2, with a reverse ordering of the 2 treatments. Outcome of therapy was judged by the following parameters: improvement in functional oral intake, physiologic changes, increased use of suprahyoid and longitudinal pharyngeal muscles, and improvement in patient perceived quality of life. During the baseline phase, subjects were administered the functional oral intake scale to determine their degree of limitation in oral intake. Other measures during this phase consisted of the Mann assessment of swallowing ability and video fluoroscopy to determine the most appropriate food or liquid modifications to be used in therapy. Each patient was also administered the swallow quality of life to establish their perceived impact of dysphagia on their day-to-day living. After the initial baseline phase, participant 1 received 45 minutes of indirect therapy, including the Masako maneuver and effortful swallow exercises, 5 days a week for 3 weeks. At the conclusion of the 3 weeks, swallowing function was assessed by video fluoroscopy, and the participant completed the swallow quality of life. Treatment was removed and baseline was reestablished. Then the patient was administered 3 weeks of direct therapy involving postural changes and bolus manipulation. At the completion of this phase, video fluoroscopy was conducted again to assess swallowing function, and the swallow quality of life was administered again as well. Participant 2 followed the same sequence of events, however, the order in which treatments were administered was reversed. During the final baseline phase following the completion of the second treatment, the Mann assessment of swallowing ability, video fluoroscopy, and the swallow quality of life were administered a final time. In order to monitor performance during treatments, clinicians recorded successful swallow attempts and took data on bolus type attempted during direct treatment and any occurrence of coughing, throat clearing, or expectoration. Every Other day, SEMG recordings were obtained that measured the duration of muscular involvement in practicing the exercises or in swallowing boluses. The data recorder and outcome assessors were blind to the status of each participant, and each treatment was administered by a highly qualified speech pathologist who conducted the sessions according to treatment protocols. So that is our research plan. I hope you enjoyed. Thank you.